Hello, I'm recording this talk on behalf of the UK Renal Pharmacy Group. This is a talk about AKI and CKD for the non-renal specialist pharmacist. What do the kidneys do? Well, the kidneys have a role in excretion and regulation, such as fluid and potassium, toxins and drugs. They also have a role in the synthesis of erythropoietin, activation of vitamin D, excretion and degradation of other hormones, and also in the production of renin. They also have a physiological role as well, maintenance of acid-base balance, control of blood pressure and anemia. And the things that the kidneys actually do help us to understand what might go wrong when the kidneys aren't working so well. So a brief recap of the kidneys. Simply put, the kidneys regulate salt and water, remove waste from the blood into the urine, regulate blood pressure, create erythropoietin to produce red blood cells, and they keep the bones healthy and they excrete drugs. And K. Diego states that the kidney is a fairly robust organ that can tolerate exposure to several insults without suffering significant structural or functional change. For this reason, any acute change in kidney function often indicates severe systemic derangement and predicts a poor prognosis. What is AKI? Well, AKI is a rapid deterioration of renal function over hours or days, and it's characterised by reduced urine output and/or an increase in serum creatinine. Urine output can be looked at in a very minute to minute, hour to hour. Serum creatinine often shows what was happening yesterday or the day before and lags behind. AKI is defined as a significant deterioration of renal function, as I've said, over hours or days. It can result in a failure to maintain fluid, electrolyte and acid-base balance. And it can be staged based on severity. An increase in severity of AKI correlates with higher risk of worse outcomes. So AKI comes as 3 stages. Stage 1 is 1.5 to 1.9 times the baseline, and the baseline creatinine is the lowest creatinine in the last 3 months, or a 26.5 or 27 increase in the last 24 to 48 hours. Stage 2 is a 2 to 3 or 2 to 2.9 times your baseline, and a stage 3 is 3 times, or greater than 354, or requiring renal replacement therapy. Urine output has also been measured. So again, it's a reduction in the usual urine output for 6 to 12 hours. Less than 0.5 mils per kilo per hour for more than 6 hours. And again, getting worse as the stages go on. We have NICE guidance that tells us what to do, published in 2019, and that suggests that we should identify AKI in patients with acute illness and at risk of AKI. So we need to think about those patients that are at risk and think about how we're going to treat them. We need to investigate AKI by measuring serum creatinine and comparing with the baseline. And we need to prevent AKI in anybody having contrast. We need to perform a urine dipstick, looking for blood and protein, not looking to see whether the patient's got an AKI. We need to document the results and make sure that we appropriately action them. We need to review medication and withhold any nephrotoxic medications, especially this hypovolemia. And we need to refer to a nephrologist if it's stage 3 or as a possible diagnosis that might need specialist treatment. So pharmacists have a big role to play in AKI. Early recognition is really important. AKI is not just a secondary problem, and about 65% of AKI cases begin in the community. So primary care has a crucial role to play in identifying those patients at risk, looking at identifying them early and managing them, as well as what happens with post-AKI care after the patient's had an AKI. There's an increased risk of poor long-term outcomes, even in those that are not admitted to hospital, reduced life expectancy, increased cardiovascular risk, poorer quality of life. And so early detection is likely to improve prognosis. And up to 30% of deaths from AKI are thought to be preventable by early recognition and correct management of patient risk factors. Use of electronic systems provide alerts. For example, pathology systems can help with this. And the aim is to prevent admission and prevent progression from a stage 1 to stage 2 to stage 3. Mortality increases as the stages go up. So a stage 3 AKI has about a 50% mortality at 3 months. And all stages of AKI have got about a 50% mortality at 1 year. And having an AKI and multiple AKIs will show a risk of frailty, increasing signs of frailty in the patient. Prognosis. AKI is multifactorial. So epidemiological evidence suggests that AKI has important clinical consequences, even in mild reversible cases. The prognosis of AKI varies depending on the clinical setting, underlying cause, and any comorbidities. Complications arise as a result of impairment of the kidney's excretory, endocrine, and metabolic action, as we discussed at the beginning of the talk, and the risk of complications is related to the stage of AKI. The worse the stage of AKI, the more risk there is of hyperkalemia and other electrolyte imbalances, metabolic acidosis, and volume overload. Uremia can also be a problem in higher stages of AKI, and having an AKI increases your risk of not settling back down to baseline and having some sort of CKD and progressing therefore onto end-stage renal disease. What are the common causes of AKI? Well, the most common cause is a pre-renal cause, and that's a reduction in blood flow into the kidneys. The kidneys like a good blood flow, so when the blood flow reduces, they don't really like it very much. Hypervolemia, reduced cardiac function, sepsis, drugs, all of these can have a pre-renal cause. Post-renal could be bladder outflow. There could be something blocking. It's something blocking the outflow to the kidney, and that can often cause a very high increase in creatinine that can come down really quickly once the blockage is gone. There can be an intrinsic cause, so that's where drugs, or there could be a glomerular disease or interstitial nephritis. That's where you actually need a nephrologist involved to help with that. And actually 80% of causes of AKI are pre-renal. And these are treated quite easily. If the patient has got an infection, they're dehydrated, perhaps got nausea and vomiting, they're not keeping fluids in, that can be really easily treated with rehydration. 10% are post-renal. Again, these can often be quite easily treated with unblocking whatever's there. And about 10% of them will be an intrinsic cause. And actually, in fact, only about 7 to 8% of patients with an AKI are ever seen by a nephrologist. So what do we know about drug causes? Well, drugs, as I've put in here, can have different effects on the kidney. So you could have a pre-renal cause. So diuretics can reduce your blood volume, therefore causing an AKI. Non-steroidals, ACEs and ARBs, CNI, so tacrolimus and cyclosporin, all of those can have a pre-renal cause. Post-renal is usually caused by obstruction, but that could be crystals caused by acyclovir or things like that can cause crystals, so that can also cause that post-renal blockage. Intrinsic, we can have an ATN or acute tubular nephrosis, and that could be aminoglycosides, acyclovir, that can be the tacrolimus again, lithium, vancomycin, and contrast can all have an effect on that. And acute interstitial nephritis is something else that can be caused by things like allopurinol, azathioprine, erythromycin, can all have an intrinsic cause. About 5 to 20% of AKI cases are caused by drugs. ATN is the most common cause, and it's a manifestation resulting from a direct toxic effect. The acute interstitial nephritis, normally you'll get some proteinuria and some hematuria and perhaps a fever or a rash, and these can actually take quite a few months to recover from. So what do we know about our risk? How are we going to identify our patients that we're looking after to try and reduce the risk of developing an AKI? Well, some of these things are modifiable risk factors and some are non-modifiable. So if you're over 75, you've got an increased risk. If you're hypotensive, if you've got sepsis, hypervolemia, if you've got CKD already, you've had a previous AKI, you've got heart failure, diabetes, peripheral vascular disease, all of these things are potentially non-modifiable. But modifiable risks can be you're on an ACE or an ARB, you've got hypervolemia, so you've been vomiting and not keeping fluids down, sepsis and hypotension. All of those are modifiable. We can do something about. So we can see that we can identify the patients that we think are most at risk. So if you've got a patient that you're looking after that's over 75, that's in their 80s, they're on ACEs and ARBs, they've got CKD and they're diabetic, and something else happens, they perhaps get a UTI or some sort of infection that they're then not keeping fluids down, they're being sick and vomiting, those things can be that trigger factor that can push them over into an AKI. So identifying the risk is really important, identifying which of our patients we need to watch for most closely, whether we're in the community or within the hospital. The right response is really important. So eliminate the cause of AKI if you can. If they're dehydrated, rehydrate them. Avoid certain medications or stop them if they're already on them. So think about the ACEs and ARBs. We'll come on to sick day rules in a moment. Think about the diuretics. Think about, are they on non-steroidals or metformin or things like gabapentin? Are they on medications that can exacerbate the AKI? Again, AKI is multifactorial. So in those patients that are at risk, they're dehydrated, don't give them a non-steroidal, okay? Is the patient prescribed in medication where the dose needs to be amended? So is the drug going to accumulate in renal impairment? So the things I'm thinking of when I look at people's drugs are digoxin, allopurinol, gabapentin, opioids, those sort of things that are likely to accumulate. Monitor UNEs and reassess renal function daily. We need to be calculating what dose of drugs to do as the renal function changes. And we'll look at that a bit more clearly in the CKD section, but assessing renal function daily and altering those drugs is really important. Counsel the patient if you've stopped something, when to restart it, and which medications to avoid and not restart, and why. So could my patient have an AKI? Look out for the signs and symptoms. So they could have a reduced urine output. We've talked about that already. They could have a change in colour to their urine to make you think they're dehydrated, have nausea and vomiting, dehydrated, thirsty, confusion or drowsiness, and increased creatinine compared to the baseline. But if you don't have access to blood results, you can have a look at some of those other signs and symptoms to start with. And think about any other risk factors that that patient has got. Think about flagging those patients on your electronic systems. Hopefully in the near future, we'll be able to have a system of flagging those patients on our GP systems to show these are my patients that I think are at risk of an AKI. So when they come in with X, Y, and Z, those are the patients I'm going to be particularly worried about. Are they having a risk event or a trigger? And I'm going to suspect the AKI. So I think my patient's at risk and I'm now suspecting. Think drugs. Think about your sick day rules. Think about assessing them. Are they passing urine? Are they dehydrated? Look at their urine colour. Remember, there's a really nice thing from the Think Kidneys website. Healthy P is 1 to 3, 4 to 8, you must hydrate. So it's looking at the darker the urine, the more dehydrated the patient is likely to be. And do they need emergency admission or referral to the GP? Do I need to do something more than what I can do for them? Prevention, sick day rules, okay? Patient information and awareness. There's lots of information and resources on the Think Kidneys page. About 50% of patients don't even know what their kidneys do. They don't know that the kidneys produce urine. So trying to get them up to speed with it, trying to cause an AKI is a step too far for some patients, but understanding what they can do for themselves is important. Think about the patients in care homes. Think about making sure they're well hydrated. Thinking about the very hot summer days, very tight, or the patients that are unwell, making sure that they're hydrated well. Fluid balance. Make sure somebody's monitoring fluid balance a little. And some care plans. I've mentioned heat waves. So again, think risk. What risk has my patient got? Think trigger. Has my patient got a trigger now? And think kidneys. Okay, so I've talked a little bit about sick day guidance. We used to call it sick day rules. We've now changed it to sick day guidance. We just need to be careful because in some patients that could be harmful. But we need to empower our patients. And we need to remember this when we speak to our patients as well. So we should empower our patients that if they're unwell for more than 48 hours and they're not keeping fluid down, so they're at risk of dehydration, then we need to advise them to withhold their ACEs and ARBs, withhold their metformin, and withhold their SGLT2 inhibitors, but to always take their insulin doses, so not to stop that. But we need to think about those patients where there may be harm. So those patients with heart failure, with severe heart failure, shouldn't be stopping their ACEs. And we need to have them to have the conversation with their heart failure team to see whether they should be stopping or not. Again, thinking about diuretics, that's going to do our heart failure patients some harm, so we need to be careful. Again, watching for hypertension. Often if the patient's dehydrated, they'll be hypotensive, but perhaps monitoring their blood pressure would be a good thing for them to be doing. And reduce adherence. Think about the message that we're giving to the patient. Don't say they're nephrotoxic, because the patients then may not take them at all. We need to think of a way of making sure that the patients think that they're withheld rather than stopped, because they're upsetting their kidneys while they've got something else going on. In normal conditions, they're not harmful to the kidney. And patients may overinterpret the advice. So we need to be really careful at making sure they restart them so they get the benefit from their ACEs and ARBs, but we don't give them that AKI. Okay? And think about diabetic patients. And again, the heart failure patients are the ones that we're really worried about, making sure that they are not stopping their drugs. Nephrotoxic medication. So think kidneys, okay? There are very few medications that truly have a direct effect on the kidneys, but several have the potential to impair the kidney function if used under certain circumstances. And again, think about multifactorial for the kidneys, okay? In a very healthy, young, healthy person with no other risks, no other comorbidities, these drugs are not going to cause a problem to the patient. But if the patient's got lots of other risk factors, this could be the thing that tips them over the edge. And think about the medications that are cleared via the kidneys. They have the potential to accumulate during an episode of AKI, and that may result in further deterioration of the kidney function, or it may cause other adverse effects, CNS toxicity, for example, the patient fitting. So think about amending doses to the level of the patient's current renal function. Think about medications with a nephrotoxic potential, and think about renal offending medications. Okay? There's a very nice document on the Think Kidneys website on medicines optimization, which makes a very good read. And remember, AKI is multifactorial. Think of the risk factors plus infection and drugs and dehydration. So hopefully I've gone through the main points, but there are three main types of problems with AKI. Firstly, there's effect on the renal function itself, on fluid and electrolyte physiology, changing the side effect profile where renal function is reduced, and a direct action on the kidneys. So we should be performing a medication review on those patients with an AKI, eliminate the potential cause of AKI. As I've said, some drugs can be the cause, eliminate the risk of tipping them into an increased AKI stage, and think about the contributing factors. Avoid inappropriate combinations of medications in the context of AKI. We can reduce adverse events, and we can ensure that the doses are appropriate for that patient's renal function at that time. And think about AKI and comorbidities, and ensure which ones are held, it happens appropriately, and when we perhaps give an alternative, and to say when to restart. The questions to ask: which medication should be suspended? Which medication should not be suspended? Which should be used with caution? And are there any therapeutic options? We can think about the actual pharmacokinetic and pharmacodynamic properties of the drug to know which are our best drugs to be using. Ask yourself those questions. So medicines optimization, again, this just recaps what we've already said. So think about, is the patient prescribed any of the following? Consider withholding and perhaps discussing with the GP. Are they on ACEs, ARBs, diuretics, metformins, non-steroidals, SGLT2 inhibitors? Think about, is it appropriate for them to continue or not? Think about antihypertensives. What's the blood pressure, patient's blood pressure at the moment? What's their fluid status? Think about, are they hypotensive and dehydrated, and do they need antihypertensive? Think about, there's been any recent use of contrast media. Has the patient been admitted for a scan and had some contrast? And that can typically have an effect on the patient, perhaps 3 to 5 days later, cause a problem with the kidney. Calculate the creatinine clearance. Think about the eGFR. Think about what the patient's baseline renal function is when making your recommendations, and consider whether any of the prescribed drugs may exacerbate or cause harm to the patient. Some of these drugs are going to accumulate. So what? Opiates, antibiotics, acyclovir. This list is not exhaustive. Look at the Think Kidneys website, but covers some of the more commonly prescribed medications that may require dose reductions in AKI and in CKD as well. Monitor UNEs, assess renal function frequently. Think about TDM, think about monitoring what the levels of the drugs are. Think about when to restart and educating the patient. And remember also to communicate this to the GP, that the patient's had an AKI and what stage. It's really important for the GP to know, and also communicate what drugs have stopped, whether they should be restarted, when to restart, and how to monitor the patient when restarted. So look at the original indication for the drug. Do we need to restart that? Was the patient on an ACE or an ARB just for hypotension? They've got no proteinuria, or were they on it because they're diabetic or heart failure? Okay. Think about when and how the medicine should be restarted. Should any of them be discontinued? So non-steroidals, not to be taken again. Think about contraindications for the drug. So has the patient got a renal artery stenosis? Think about the patients that have been previously stabilised on drugs for heart failure. So we need to restart them as soon as possible. We don't want the patient to bounce back into hospital if those drugs are not restarted. Follow the existing guidelines to identify the high-risk patients, and think about the patient holistically, taking into account the overall functional status of the patient. What's the blood pressure? And is there an opportunity to rationalise medications? We don't need to restart everything. Avoid any unnecessary polypharmacy. Okay, so that was a little bit of a look around AKI. We should be monitoring the patient for 3 years post any episode of AKI. Have a look at the Royal College of GPs toolkit for post-AKI care and how to monitor the patient. And as I've said, many of the patients with AKI will not go back down to baseline, so they may end up with a degree of CKD. So now I want to go through a little bit of information about CKD, or chronic kidney disease. CKD is a worsening, progressive or irreversible loss of patients' kidney function over months to years, leading to dialysis or transplantation. It affects about 5 to 10% of the population. And many people will not know they've got CKD. At the moment, I think there's about 3 million people in the UK with CKD, and that's predicted to rise to about 4.5 million by 2030. So that's a huge proportion of patients, and many of those don't know they've got CKD. So how do we define CKD? Well, NICE have given us a definition. It's an abnormality of kidney function present for more than 3 months. So it's not a one-off, it's over at least 3 months. And we do that classifying it on EGFR. So AKI, we were monitoring creatinine and urine output to say what stage we've got and whether we're back to baseline. With CKD, we're looking at EGFR. We're also looking at the albumin to creatinine ratio, so the ACR, how much protein leaks that patient got. So we see stages of CKD from 1 to 3, 1 to 5, and then we've also got whether they've got proteinuria or not. So the lower the EGFR and the higher the ACR, the higher the risk of adverse outcomes. So the higher the risk of progression of CKD and mortality of cardiovascular events. If you're elderly and you've got CKD, you have more of a risk of dying from cardiovascular disease than you do of reaching end-stage kidney disease. So we want to reduce the cardiovascular risk in patients with CKD, because this is really important to reduce mortality. But you can see from the heat map there, that's in all of the NICE guidelines, looking at as you get down to the bottom right-hand corner, down to the red areas, that's an increased risk of progressing to end-stage. You can also use the kidney failure risk equation, which gives a better prediction as to whether the patient's going to reach end-stage or not. Some of the patients, just because they're in an amber box, they won't reach end stage. And the kidney failure risk equation is a better way of looking at it. And you can Google that, plug in the numbers, and it will give you a risk over the next 5 years. So proteinuria is really important. So we're looking at any ACR greater than 3 milligrams per millimole. It's clinically significant. The kidney should not be leaking protein. Protein loss is a sign of kidney damage, and the more proteinuria there is, the higher the decline in renal function. And albumin is the most common type of protein in the urine. And we're trying to determine the significance of this, a PCR or an ACR. ACR is much more sensitive and therefore more accurate, especially in patients with low levels of proteinuria, especially in diabetics. And we should be using an early morning urine sample where possible. Albuminuria or proteinuria is clinically significant. Creatinine. Again, we're monitoring creatinine, but it's produced continuously in muscle. So if you've got a low muscle mass, you'll have a low creatinine. So some patients with very low creatinines, which is why it's really important to look at the trend, because if you've got a very low creatinine of 39 or 40, you can have an AKI even if you're still within the normal range. So it's really important to look and see what the normal range is for that patient. So production declines with age, it's excreted by the kidneys, and it's linked to kidney function and muscle mass. And the reference range is usually between 50 to 120, but we really need to know what your lab is actually, what your lab range is. So creatinine clearance is only validated in Caucasians. It's not validated if you've got a transplant or an amputation, but it was a calculation that was done in the 1970s. It's what the most drug dosages are based on. So this is the one we need to be calculating when we're trying to use a drug with a narrow therapeutic range, or we're trying to use a drug with lots of side effects that we're trying to adjust for that patient's degree of renal function. We also need to think about the weight. So we need to use adjusted body weight in the obese patient, ideal body weight if they're not obese, and actual body weight if the BMI is less than 18.5. So it's really important to get the right weight and the right height And using MD Calc is an app which is very, very accurate and very good at looking at this, and will give you those different, if you put in the patient's height and weight, it will calculate it for you. Estimated EGFR, again, this is not validated if you're pregnant or in AKI, or you've got muscle wasting or diabetic or transplant. So they have their limitations, but this is what actually comes out on most of the lab systems. And again, it's given a renal capacity if your body surface area is 1.73 meters squared. So the majority of patients are not 1.73 meters squared. So it's only accurate if you're of average. So you could work it out and change the body surface area in order to get a more accurate one for the patient. But this is very good because it doesn't need a patient's weight. So the lab can calculate this, and it's very good at staging what stage of CKD the patient's got. CKD epi is what's recommended in the latest NICE guidelines. And this is because it's actually a better predictor of CKD, better at the limits of CKD. So it's really important to find out what does your lab report, and also to establish trends with the previous results. So this is a nice way of looking at it. If we want to know which equation to use, we've got a youngish, very muscular man, and we've got an elderly, very skinny lady. They've both got the same creatinine, but have they got this same renal function? So he's 90 kilos and 20 years old, so he's got an EGFR of 95. She's only 50 kilos and she's 75 years old, so she's got an EGFR of 45. So although they've got the same creatinine doesn't tell you the whole picture. You need to look at what the other criteria are for the patient as well. Get their EGFR to see what's going on. So she's got stage 3 CKD, and he has got normal renal function. But what is their creatinine clearance? If we're looking at some drugs like valganciclovir or gentamicin that are doses based on creatinine clearance, using the EGFR may put us into the wrong dose banding and give us the wrong dose. So if we actually calculate the creatinine clearance, his creatinine clearance is 121 and hers is only 31. So for him, it would make no difference which equation we use to calculate a drug dose for him, but for her, it would make a difference. And we would overdose her if we were to give her something like valganciclovir, and possibly give her toxic side effects, and that's not good for us. It's really important to know why we're using the different equations. So we have CKD NICE guidance, NG 203, published in August 21, and it was updated in November 21. So this is looking at how we should be treating our patients with CKD, investigations for CKD, classification, blood pressure control, what medications we should be using, phosphate binders, etc., etc. And this suggests that we should be referring to a nephrologist if our 5-year risk of progressing to end stage is greater than 5%, or the patient has an ACR greater than 70, or an ACR greater than 30 and hematuria, or they have a reduction in their EGFR of greater than 25%, or 15 mils per year. They're hypertensive, or they have a genetic cause of CKD, like polycystic kidney disease, or they've got renal artery stenosis. In those sort of patients, we should be referring them to a nephrologist for treatment and looking at what they can do to prevent progression. The other patients we should be looking after within the community. So let's have a little refresh. What do our kidneys do? Well, the kidneys are involved in excretory and regulatory functions. So they're looking at excretion of potassium and acid, toxins and drugs. They're involved in metabolic processes, so synthesis of erythropoietin, activation of vitamin D, production of renin, and physiological acid-base balance. And then we can see what sort of things we're expecting the kidneys to be involved in as they fail. So we're expecting to be looking at anemia management. We're expecting to think about calcium and vitamin D homeostasis, parathyroid hormone. We're expecting to think about hypertension. So the kidneys, as they fail, stop excreting so much fluid, potassium, phosphate, and drugs. They stop producing erythropoietin, they stop activating vitamin D, but they will still produce a renin. So they're still involved in the renin aldosterone process, and therefore hypertension can be a problem. So pharmacotherapy in CKD. So our aim is to prolong the time to end-stage kidney disease and to reduce cardiovascular mortality on the way there. As I've already said, the patient an elderly patient is more likely, with CKD, is more likely to die of cardiovascular disease than they are to progress to end stage. So we need to stop that cardiovascular disease on the way through. We need to look at blood pressure control. We need to look at statins. We need to look at antiplatelets for secondary prevention. And we need to look at SGLT2 inhibitors. So hypertension, we need to think about what is the blood pressure. Lifestyle changes, the same as for the rest of the population, looking at salt, looking at exercise, looking at achieving ideal body weight, and we often need to look at all of those. We need to individualise the treatment, taking into account the patient perspectives. So the age of the patient, so that we don't want postural hypotension in the elderly. So accepting a higher blood pressure in the elderly means that we're not going to have them falling over. And the target blood pressure should be 140/90. We should aim for a lower blood pressure of 130/80 if they're diabetic and they've got proteinuria. We need to think about using ACEs and ARBs if they're diabetic or they've got proteinuria, and I'll come on to that in a minute. We can use beta blockers, calcium channel blockers. Thiazides are ineffective when you get down to low EGFR, alpha blockers, and occasionally moxonidine. And often the CKD patient or the dialysis patient will be on lots of different medications for their blood pressure. And it's about starting the dose low and increasing slowly in order to get to the maximum tolerated dose and to keep the blood pressure down. Having a high blood pressure can drive the CKD, so getting the blood pressure down is really important. So what are the role of the ACEs and ARBs? We need to, again, be measuring the ACR of our patients. So if we know a patient's got hypertension or diabetes, we need to be measuring their ACR. If you've got an ACR less than 70, then we should be looking at a target blood pressure of 140/90. If their ACR is greater than 70, firstly, we should be referring them to a nephrologist, but also we should be targeting them to 130/80. We need to think, are they diabetic or non-diabetic? So if you've got a diabetic patient and the ACR is greater than 3, we should be starting an ACE or an ARB. If it's a non-diabetic patient, then actually if the ACR is less than 30, follow the NICE guidelines about the age, whether we're using ACEs or ARBs or a calcium channel blocker. If the ACR is greater than 30, then we should be starting them on an ACE or an ARB. So ACEs and ARBs have been shown to reduce proteinuria and to therefore prolong the time to end-stage kidney disease. So it's the only changing drug we've got for proteinuria that's happened, and we've been using them about 20 years, and they'll give you about another 5 years in reduction in progression to end-stage kidney disease. So think about measuring the ACR, diabetic, non-diabetic, and when do we use our ACEs and ARBs? SGLT2 inhibitors. So this is the new thing that's coming along, and I've put on here, coming soon to 91,000 people near you. So again, we need to know who our patients are. As I've already said, there's millions of people with CKD. Many of these patients, we don't know who they are. Think about the patients with diabetes or hypertension. Make sure we're measuring an ACR in these patients yearly and looking then if they've got a raised ACR, thinking about getting them on an ACE or an ARB and then adding in an SGLT2. As I've said, we've been using ACEs and ARBs for about 20 years for proteinuria, and they'll give you about an extra 5 years. The SGLT2 inhibitors in the studies have been shown to give you another 15 years on top of that 5 years before reaching end stage. So we have canagliflozin, empagliflozin, DAPA, to all these different ones that we've got. And they've got slightly different licenses. So it's important to know what the license is as to which patient you're going to be using it for. EMPA-KIDNEY is a study that was going to report hopefully in 2023, and we should have some more evidence about that as to whether it's a class effect. At the moment, we have the CREDENCE study, which is canagliflozin, and they looked at the low, and they showed that it actually lowered the risk of kidney failure and cardiovascular events. And they were looking at an EGFR greater than 30. So canagliflozin is only licensed with an EGFR greater than 30, and this was in type 2 diabetics. And again, the study showed that it prolonged the time to end stage by 15 years. The DAPA-CKD study was a very similar study, but it looked at patients with a slightly lower EGFR, so down to 25 and 25 to 75. And this one critically looked at diabetics and non-diabetics. It also looked at an ACR greater than 300. And it looked at those patients that were on maximum tolerated ACE or an ARB. And they added dapagliflozin or a placebo. And they showed that actually there was a 39% reduction in progression to end-stage kidney disease, 29% reduction in cardiovascular mortality, and a 31% reduction in all-cause mortality. So these patients had a reduction in progression to end stage. They weren't dying of cardiovascular mortality, but they also, more importantly, weren't dying of other things either. So this is really important to our patients, looking at reduction of your EGFR, end-stage kidney disease, or death from a renal cardiovascular disease. This is game-changing to the patients. If we can get the right patients on these, we can prolong the time to end stage. And this is really important that it's for diabetics and non-diabetic patients. We have nice guidance to guide us in this. But be aware of what the license is for each individual drug, because DAPA's license right down to an EGFR of 15. It's important to know what the license says. So a few other things about CKD. So we've said that kidneys are involved in anemia with the production of erythropoietin. So when the kidneys fail, they fail to excrete erythropoietin. Patients will be uremic and therefore not absorb much iron. They become iron deficient. So we need to think about correcting any iron deficiency, and then we need to think about erythropoietin stimulating agents, so our ESAs. And we're trying to maintain our hemoglobin from 100 to 120, as per the NICE guidance from last year. And then we have more NICE guidance from 2022, looking at the use of HIF inhibitors as well. So roxadustat has been licensed this year, and there'll be other stats that come onto the market in the next year or so that we need to see what the guidance and the license actually says as well. So we can use things like epoetin alpha, darbepoetin, epoetin beta, and zeta can all be used to try and correct anemia. We need to be cautious in malignancy, hypertension, and a high hemoglobin. So we don't want to push the hemoglobin up to a normal range. We want to maintain it between 100 and 120. All of these agents require adequate iron stores. So we need to get a ferritin or a TSAT into the range before starting erythropoietins or a HIF inhibitor. So we need to think about HIF inhibitors are oral medications that we can use to try and stop the patient from being anemic, or ESAs are subcutaneous. So we need to think about iron as well. So what iron we're going to use? We can use Venofer, Ferinject, Monofer. All of these are different intravenous irons we can use, but we have a risk of anaphylaxis and skin staining with an MHRA warnings for intravenous iron. But we need to make sure the patient's iron replete, and then we can start a HIF or an ESA. We need to think about reducing phosphate levels. As I've said, the kidneys excrete phosphate. When the kidneys aren't excreting so much, phosphate levels will go up, and that can then affect the calcium level, and therefore phosphate goes up, calcium goes down, and that triggers a parathyroid gland to produce more PTH, which then sets off the calcium homeostasis cycle, which you can have a look into in a bit more detail. So we need to think about restricting the patient's diet. So things that are high in phosphate are things like cheese and milk and processed foods. So the patient will be restricting those. And then they might be on a phosphate binder. So these phosphate binders are taken with food. So when they're eating a meal high in phosphate, and that might include calcium acetate, calcium carbonate, sevelamer, lanthanum, and Velphoro. All of these things are phosphate binders that you might see patients on. Dialysis also is very good at removing some phosphate, but many of these patients will have GI side effects with these. As the NICE guidelines would have a calcium-based one first line, as it's cheaper. And then if that's not tolerated or the patient is hypercalcemic, you can then use things like sevelamer or lanthanum. Lanthanum is very expensive, it's not as effective. Aluminium hydroxide was a fantastic phosphate binder, but it's been withdrawn from the market. Again, potassium binders. So we were talking earlier about ACEs and ARBs, and sometimes we can't push the patient's ACEs and ARBs dose up as high as we'd like to reduce the risk of heart failure and progression of CKD due to the patient becoming hyperkalemic. And we have two nice TAs, one around Lokelma, which was sodium zirconium cyclosilicate, or Patiromer, looking at the use of these two medications. So we are able to use these as per license and as per NICE guidance for the emergency treatment of acute hyperkalemia. So looking at a patient with a very high potassium, we can use them over the 2 or 3 days to bring the potassium down, but we can also use them in chronic outpatient treatment. So potentially the patient that's come in with acute hyperkalemia, been treated, we can then continue this. So the NICE guidance again would say that they would have required a potassium greater than 6, and they're not on optimized dose of a RAS inhibitor because of hyperkalemia. And we can do this in primary and in secondary care. So the NICE guidance says that we can start it or for patiromer in secondary care and continue, and sodium zirconium cyclosilicate can also be continued in primary care. And you may find that you've got local guidance on how to do that. But some sort of pathway is really important because the patients need to reduce their cardiovascular risk and their renal risk by using ACEs and ARBs, and they may require a potassium binder. And this would then mean that potassium is monitored very regularly for the first 2 to 4, 6 weeks, and then after that, you can just monitor alongside the RASI therapy. Acidosis. Acid is buffered through the kidneys, and this reduces as the CKD progresses, and serum bicarbonate levels will fall. We're aiming for normal levels of 20 to 29, and we may find that we give patients sodium bicarbonate, 500 milligrams 3 times a day, and we'll titrate that dose according to what their bicarbonate level is. There is some evidence also that giving sodium bicarbonate reduces renal function decline. Many patients won't tolerate sodium bicarbonate, and there's a prolonged release one called Nephrotoxic that these patients might be able to tolerate. But again, it's about continuing on this for a long period of time and titrating it to aim for those levels. Prescribing considerations in CKD. So think of the reference sources, which I'll go on to in a moment. Avoid the drug if you're not sure. The golden rule of starting low and titrating up. Alter the dose or the dose interval. So reduce the dose or increase the dose interval in patients with an AKI or CKD. Monitor what the creatinine's doing and monitor the effect of the drug. Watch for interactions with hospital prescribed medication. So many patients will be on drug medications through a hospital. Think about the drugs that you're using and whether that's going to interact with them. Make sure that all of those, there is a way of recording every medication the patient's on. Think about timing with other medications. Don't give calcium binders with iron, for example. Consider the tablet burden in these patients. Many patients with CKD will be on a phosphate binder. They might be on an iron. They'll be on some aspirin. They'll be on 2 or 3 antihypertensives. They'll be on a phosphate binder. They might be on diabetic medication. There's a huge tablet burden in these patients. And also think about the fluid intake in fluid-restricted patients. So somebody on dialysis may have a fluid restriction of 750 or 1,000 mils a day. Think about if you've got to take all those medications, what you're going to need to do. So renal function should be checked before prescribing any drug which requires a dose modification in renal impairment, and monitor it regularly. So renal replacement therapy, again, I don't want to go into this in too much detail, but dialysis is started when indicated by the impact of living with symptoms of uremia, biochemical fluid overload, or hyperkalemia. Think about the diet. So hyperkalemia, we can use patiromer and low-calma, but we can also think about the diet. So think about things that are high in potassium, so oranges, bananas, coffee, avocado. All of those things are high in potassium, and the patients can avoid those to try and prolong the time to requiring dialysis. Ensure the medications are dose adjusted for when the patient has dialysis. Think about which sort of dialysis they have. So renal replacement therapy could be hemodialysis, or it could be peritoneal dialysis. So hemodialysis happens 3 or 4 times a week, and peritoneal dialysis happens continually. Have a conversation with your local renal pharmacist about about more information about dialysis if you want that, or have a look at the RPG website, and we have leaflets about dialysis that you can have a little look at. But ensure the medications are dose adjusted for when the patient has dialysis. Some patients will have conservative care, so we may not dialyse the patient at all. We just may conservatively manage them, which still means active treatment, but just means they won't require dialysis when their EGFR drops down low enough to require it. And some people will actually have a preemptive renal transplant. So we'll be watching them in the CKD clinic, and when their kidney function gets low enough, we'll then either list them for a transplant or they'll have a transplant from a living donor. And that's a very good way of managing their CKD. For those patients with a transplant, we need to think about what medication they're on and whether that A, causes any problems, and B, do we need to think about drug interaction. So cyclosporin and tacrolimus are medications that you need to, they're narrow therapeutic range medications, and you also need to think about which brand you're doing. So a lot of the time, the patients will be on a different sort brands of tacrolimus. There's Adiport, Advograph, Prograph, and Envasus, and there may be more in the future, and there are other ones that are available. We need to think about which preparation the patient's actually on. Is it once a day or twice a day? And making sure that we're not interacting or switching the patient in between the different drugs, because they're not bioequivalent. We need to be monitoring the patient's tacrolimus levels regularly, and we need to not be switching products. Think about other interacting drugs. An interaction we commonly have is clarithromycin and erythromycin or fluconazole with tacrolimus. Giving the patient any of these drugs can increase the tacrolimus levels, precipitate an AKI, and precipitate a reduction in their renal function and potential damage to their transplants. It's really important not to give clarithromycin to these patients. Transplant patients also avoid non-steroidals as well. So a little bit of further reading. Have a look on the Renal Pharmacy Group website. There are some leaflets there about the different about AKI, CKD. There's some other talks on there as well. Have a look at the Think Kidneys website. Have a read of the NICE guidance. There's NICE guidance for AKI and CKD. Have a look at the SGLT2 inhibitor guidelines. There's the Renal Association or the UK Kidney Association website. There's lots of information around on the website. Okay. And some useful resources might be the BNF, the EMC, also the Renal Drug Handbook. So some of the drugs that are licensed at doses because nobody's ever looked at what happens in renal impairment. So some of the very older drugs, there's no information about renal impairment at all. So the Renal Drug Handbook is a very good source of what has actually been done in practice. And the UK Pharmacy Group, Renal Pharmacy Group, have a look at their information and the antimicrobial therapy. Thank you very much for your attention, and please have a look on the RPG website for any further information. Thank you very much.